Hi, Claire. How's it going?
Hi. How was your weekend?
Oh my gosh.
Very exciting.
I have a niece, which is so exciting.
So great.
My the little baby girl was born. You can hear in my voice, I think I am gushing over this.
Yeah.
Sweet
Congratulations.
baby.
It's so thrilling and exciting. Yay.
Thank you. Yeah. I was telling you earlier this morning, like I've never really interacted with a newborn or even like a young baby before. So
Wow.
it is going to be a wild journey and a lot of trips up to Portland in my near future. So
that's so crazy to me. You don't have any younger siblings.
No, I'm actually an only child.
You are, that's right. I did know that.
Okay. My only way to be an aunt is through my boyfriend right now. So hopefully things keep going in that direction.
Yeah. Nice.
But I'm very excited. But
it's so great.
Yeah, thank you. Okay, so I will take us through the headlines this week. This week we had a story about Tom Curran suing Children's Mercy Hospital for quote unquote wrongful termination. And if Paul were here, that would probably be the one that we focused on for the podcast. It has all of the features of his favorite kind of story. It has a juicy lawsuit. It talks about funding. And most importantly, it has beautiful architecture as a key feature of the story. So he would definitely want to talk about that. But as he is not here, me and Claire are going to be talking about a different story. I think it was our story 3 last week, Paul wrote a story about Tom Sellers stepping down as director of OHSU Knight Cancer Center and Lisa Cousins stepping up as interim director. We had a guest editorial by Ashley Cannon, clinical program manager at Informed DNA, about how genetic counseling can improve the clinical trial process. We also had 2 obituaries for Thomas B. Tomasi Jr., who was the president and CEO of Roswell Park for a decade. One obituary was written by Roswell Park, and the other was written by Tomasi's mentee, Jerome Yates. Tomasi died at 97 years old. We also, just as a heads up to readers of the Cancer Letter, we have transformed our sort of standard weekly policy roundup story that has been usually like the second story in our issue, to a independent section. So you can find that under our cancer policy section for anything Washington, health policy, Trump, anything like that will be found there, as long as it's sort of in brief. But of course, we'll be doing deeper dives, and they'll be, more of a typical story as usual. But definitely be looking toward the back of the issue for your fix of Trump stuff mostly. But yeah, we had a really incredible story on the cover this week. And that's what we're going to dive into today by Claire. It was a massive undertaking. So many things that were covered. I can't wait to dive into sort of the how you got this done, Claire. But if you could first just walk us through generally what the story was, just for anybody who didn't get a chance to read it.
Sure. Yeah. So, speaking of babies, this story's been on my radar for a while. I've been wanting to write it. It is about adolescent and young adult, or AYA, patients with cancer who we, recently found out, according to a JAMA study, that only half of them are having a conversation about fertility preservation. Right. So there's no secret that most cancer treatments can negatively affect future fertility. So this fertility consultation is a really important and necessary part of cancer care before undergoing cancer treatment, but only, 1 out of 2 patients are receiving it. So that was the impetus for the story. That study came out a few months ago. But then just this past month, ASCO also updated their guideline on the standard of care for including this fertility conversation after cancer treatment as well. So during survivorship. I love these kinds of stories. I got into journalism because of my reproductive health reporting. Essentially, my master's thesis was on a pregnancy-related condition. So this area of healthcare is really fascinating to me. And there tend to be a lot of these kind of standards of care that are maybe really nuanced or require a really multidisciplinary approach. And so sometimes things fall through the cracks. And these types of stories are really intriguing to me because often there's a very strong patient perspective. There's a provider perspective. And then, no one's a bad guy. It's just something is being overlooked. And why is it being overlooked? And for the story like this, there are multiple reasons why that is happening. So it was really, really interesting to report and just really personal as well. So
yeah. I'm torn between what I want to ask you next because I want to go in 2 different directions.
You can always circle back.
I think I'll first ask, who are the characters in your story? Because I think when you were sort of planning this story and telling us what you had or who you had to talk to, I was so excited by sort of the narrative journalism you were committing by who you were speaking to. So let's start with the characters, and then I would love to hear, what is actually happening with this standard of care.
Sure. So I found my two main characters who are real life friends through this advocacy group, this nonprofit called MIB Agents, which was founded by Anne Graham. It is specifically for AYA patients with osteosarcoma, raising awareness about that, which is a rare and aggressive bone cancer. So she connected me, Anne Graham connected me with two different women who were willing to speak to me, one anonymously and one on the record. So my main character is Sammy Uloa, who she's a Southern Californian native. She was diagnosed with osteosarcoma 5 days before her 20th birthday after experiencing some pain in her right upper proximal tibia for about a year. So she was a competitive runner. And had been experiencing pain, and then the MRI confirmed that. And she, learned that she was going to need to get her port placed within a couple of days and start chemotherapy within a week. I believe she started chemotherapy right or on her birthday. So really kind of high pressure situation. She does recall having a very brief conversation about her future fertility with her provider, but she describes it as being kind of brushed over. So she was really overwhelmed. Her family was really overwhelmed. And this is kind of the story I have heard over and over. Getting a cancer diagnosis when you're a young person is very shocking. There's so much to talk about. And when it comes to osteosarcoma, usually the treatment has to begin right away. So if that conversation doesn't happen within a couple of days, it's there's not much you can do. So she, didn't really talk about it, didn't do anything to retrieve her eggs or preserve fertility. And now is in complete remission at age 22 and just recently started exploring the idea of building a family, and found out, sadly, that it doesn't seem likely that she will be able to bear children in the future. On the flip side, a friend of hers that I was connected with, who we call Sadie anonymously in the story, she had a very different experience, kind of a similar trajectory for the treatment, but was given upfront with everything else this very comprehensive understanding of how this treatment could affect her future fertility. The options were laid out. She was supported. Her providers kind of facilitated the appointments that were necessary with the fertility clinic. And long story short, she ended up retrieving her eggs, and is so glad that she did. So kind of two competing stories, same diagnosis, also different, ones on the East Coast, ones on the West Coast. Yeah. So that's how I found the both of them. And just really, I felt like using osteosarcoma was kind of the perfect representative for a narrative lead, because it's very symbolic in the sense that this conversation has to happen quickly. And so for providers to be able to have that conversation, they have to be equipped, and they also have to be able to guide it, because a family that just received the news that their child, has this aggressive bone cancer is not going to be maybe thinking about fertility, or, they're thinking about the now and survival. Yeah. So yeah, that's kind of the overview. That's how I found these two women. What was your other question?
My other question?
Yeah.
My other question was what you sort of were leading up to was, why is this happening? Basically, why are people falling through the cracks on this standard of care? Because it is standard of care, right? Right.
Yeah. So, it's ASCO outlines the standard of care as being oncofertility counseling before, during, and after cancer treatment. I think what I learned was, and I talked mostly to Dr. Andy Livingston at MD Anderson about this piece, but AYA populations have been kind of systemically overlooked. NCI over the past 10 years designated them as an at-risk population. And Livingston's perspective on that is that a lot of young adults, a lot of adolescents are in a transitory period. So maybe they're applying for college, maybe they're leaving home for the first time, maybe they're in between insurance because of that. A lot of things are up in the air. So maybe their healthcare is not at the forefront of their mind. They're not living at home anymore, or something like that. And so as a result, a lot of, their healthcare maybe falls through the cracks. And then this conversation, which is a very nuanced, tricky, awkward, up until recently kind of taboo conversation for both men and women, let alone the logistics of, preserving fertility.
Yeah.
All of that, it's just, it ends up being, it's too complicated. One of my sources, Laurie McKenzie, who has joint appointments at MD Anderson and Baylor, she said that as cancer care becomes more and more complex, we're getting more and more subspecialized. So sometimes we, meaning the provider, forget to have these multidisciplinary conversations. So yeah, multiple reasons why they might be an overlooked population already, and then why this other little tricky piece might be missing for half of this population.
Yeah, absolutely. Yeah. I mean, especially just the idea that these kids in a lot of cases need to get treatment so quickly. Like, I don't know. I can imagine how that can get overlooked just on like a human level. You want to get that as fast as possible.
Yeah, of course. I mean, I think something that was reiterated a lot, whether it was the patient side or the provider side, was that no one regrets having this conversation, even if it's awkward, even if it's terrible in the moment. And both of my sources, Sadie and Sammy, both said it was awful, so uncomfortable. Your parents are there. The last thing you want to do is talk about like whether or not you want to have kids. And like, and they were, older teens. So I think like if you're prepubescent, going through puberty, it's even harder. It's an even more tricky and awkward conversation for both, for everyone, I think, which is, I think, why, the emphasis is on just the provider being able to kind of facilitate that conversation and navigate and guide a family through it, which, Dr. McKenzie has been doing for over 20 years, I believe. In the clinic. So it's very possible. It's just, you kind of have to get over that initial hump of it being awkward, but it's definitely worth the time.
Yeah, of course. So how does this work with insurance, Claire?
Right. So that's another rub. A lot of times insurance, and this is state by state, but a lot of times insurance doesn't recognize fertility preservation as medically necessary.
Wow.
So we talk at the Cancer Letter a lot about, financial toxicity and the burden of having to stop work and move sometimes to get closer to your clinic, and then just the cost of the treatment. So it's expensive. I have the numbers here so I don't mess them up, but it's about, average $10,000 to $15,000 for just the procedure to retrieve the eggs for a female. Then there's, on top of that, medications for ovarian stimulation, medications to prevent ovulation, and those can cost an additional $2,000 to $4,000. And then embryo banking and IVF procedural costs are significantly higher. As with any conversation about cancer and treatment, location matters a lot. And, if you're in a healthcare desert, if you are already, a cancer patient living with other health disparities, all of that can affect your ability to make this happen. So it's like, even if you get through these difficult conversations and you make a decision, oftentimes insurance will not cover it. So that's another piece.
That's such a bummer. I feel like it seems counterintuitive that it is standard of care to have the conversations, but the follow-up isn't necessarily standard of care, or like follow through. That's really a bummer.
And ASCO's guideline, not deadline, ASCO's guideline does make mention of the pushing to make this more medically necessary.
Yeah, absolutely. So we talked about this a little bit off camera as well, but can you put this in the context of the current policy changes happening in Washington right now?
Right. So, we just mentioned this kind of in brief in the story, but on a timely note, just the past week or two ago, the entire reproductive health team at the CDC has been, riffed or doged or whatever you call it by the Trump administration. This department had, or these folks had collected the congressionally mandated statistics on fertility clinics success rates. So without those workers, it's unclear who at the department will help fertility clinics comply with the law. So another timely bit to it. Yeah.
And that definitely won't make the situation easier. That's for sure.
Yeah.
So to end on just a happier note, can you walk me through what the implications are if a provider does have this conversation with their patient?
Yeah, I think something that came up a couple of times while I was talking to different providers and patients is that as tough and tricky and nuanced and difficult as this conversation might be, it's actually really indicative of a very, optimistic prognosis. Dr. McKenzie said that if a patient is referred to me, that's a hopeful thing. It means that we think you're going to make it through, and we think not only you're going to make it through, but you're going to be able to have a family someday. So what better news to be able to give a patient and their parents in the clinic on the same day, as an aggressive cancer diagnosis, something like osteosarcoma. So yeah, a really kind of beautiful piece to this difficult, tricky, messy conversation.
Yeah, absolutely. Well, it was lovely talking about that. I'm very happy we were able to find sort of like the bright side of all of this, the nice way to end, because this could be just kind of a sad conversation. So I'm definitely happy to hear that. And thank you for being here, Claire. And I think next week we'll have Paul back. He's back up in Vermont, so he will be skiing as often as possible. But hopefully we can get him on the podcast. All right. Well, thank you, Claire. Bye. Thank you for joining us on the Cancer Letter podcast, where we explore the stories shaping the future of oncology. For more in-depth reporting and analysis, visit us at cancerletter.com. With over 200 site license subscriptions, you may already have access through your workplace. If you found this episode valuable, don't forget to subscribe, rate, and share. Together, we'll keep the conversation going.
Until next time, stay informed, stay engaged, and thank you for listening.